What I wanted to talk about was really what I think is probably the key question for most patients when they come to clinic: which procedure should I have? Most patients have thought very carefully about the different operations. They've done research, they've looked at social media, and a lot of patients have a very good idea about which procedure they favour. But that's the key decision that we have to make in clinic, that I have to help the patient make that decision based on the patient's expectations, maybe their age, their lifestyle, their diet, and all those sorts of things. But I think I ought to start by saying that the conversation we're having this morning is very much my own opinion. It is based on research, but it's very much my experience over the past 20 years of looking after patients, interpreting that research to try and make the best decision with the patient. Now, for most patients now, the choice really is between a sleeve gastrectomy and a gastric bypass, whether that be the mini gastric bypass or the standard Roux-en-Y gastric bypass. And I think it's also, we ought to say at this point, that there really isn't that much mini about the mini gastric bypass. Sure, it's one anastomosis less than the standard Roux-en-Y gastric bypass, but it's still major laparoscopic surgery, and the risks in the short term and the longer term of the mini gastric bypass are certainly higher than a sleeve gastrectomy, even if maybe they're a bit lower than the standard Roux-en-Y gastric bypass. But for most people coming to clinic, the most important thing is knowing how much weight they're going to lose. And most people want to lose as much weight as possible, and that's really how they look at the procedures. But I think it's really important that when you're considering that question, you consider the trade-off. And there's no doubt that the gastric bypass, although it might give greater weight loss than the sleeve gastrectomy, does come at a price. It's a bigger operation. The risks both in the operative period and the longer term increase compared to the sleeve gastrectomy. It's harder to live with. It needs more long-term maintenance. It impacts more on your social life. But if you come to clinic and you see maybe one of my colleagues, people will often quote the sort of research that's been done over many years looking at weight loss outcomes with the different procedures. And these studies are based on thousands and thousands of people having weight loss surgery. And then on average, you can work out how much a typical person would lose with each procedure. And the key thing is as well that actually when you look at the bypasses compared to the sleeve, for most people, the difference isn't huge. It's about a stone. But if we take, say, somebody coming to the clinic who you might call a typical lady, who's, say, 8 stone over her ideal weight, then with a gastric bypass, on average, they could expect to lose about 75% of that excess weight, which is about 6 stone. With a sleeve, maybe 60 to 65%, which is about 5 stone. So as we said, the difference isn't marked about a stone. But the person sat in front of me may not be at all typical of the people in those trials. When you look at those trials, you have to remember the different sorts of people that are in the trials, and there's probably a lot more ladies than men in the trial, because that's typical of bariatric surgery, that ladies tend to have surgery more than men. The age range in those studies will be anything between 18 years old and 60 or 65. When you look at weights and BMIs, the range of people in those studies will have a BMI anywhere between sort of 35 to 40 and maybe 60, 65. They might be anything between sort of 15 stone and 35 or 40 stone in those studies. They might have different illnesses related to their weight. Some of them might be diabetic. A lot of them won't be diabetic. A lot of them will be different in terms of their exercise ability. Some people are very active. Some people are very sedentary. You look at their diet. Some people will favour very large portions, but mostly good foods. Some people will be grazers. Some people will have a sweet tooth. Some people will have a savoury tooth. So for that individual person in front of me, we have to try and work out where they fit into those studies to see which operation will be best suited to them. And so at this point, I think we have to look at how the different procedures work and how they help the patient lose weight. And as you know, the sleeve gastrectomy, basically we staple up through the stomach, removing about 2/3 of it, making a tube from the stomach that's uniformly 1 centimetre in diameter. And the sleeve really works in two ways. Physically, because the capacity of the sleeve is so much less than the stomach, it forces patients to eat smaller portions and they're full much quicker. But the second way that's really key is hormonal. And the part of the stomach that we remove has this specialized gastric cells in it that produce a hunger hormone called ghrelin. So by getting rid of that bit of the stomach, we get rid of those gastric cells, we reduce the patient's ghrelin levels, we make them much less hungry, much less interested in food. And that's really key. And actually that's why surgery works and why dieting doesn't, because when you diet, your body doesn't think it's a good healthy thing to do. It thinks it's a famine. It makes you hungrier and hungrier, and it makes you go looking for food. And that's why it really doesn't work. And if you see Slimming World or Weight Watchers Loser of the Year, you really need to see them a year or two later, and almost all of them will have regained their weight because they're constantly having to fight their hunger. Now, if you compare that to the gastric bypass, which is a more complicated procedure, and again, as you know, it's keyhole surgery, but this time we staple horizontally and then vertically through the stomach to make a very small pouch. And again, that pouch physically restricts portion sizes. But you then connect that pouch to a piece of small bowel, either having made what we call a Roux-en-Y for the standard bypass, or with the mini gastric bypass, we just take a loop of bowel up and join it to that pouch. So it's a more complicated procedure to perform, and that's why the operative risks are higher and why the long-term risks are higher too. But again, just like the sleeve, that works physically by restricting portion sizes, making patients eat much less. But again, there's a hormonal effect that's different to the sleeve gastrectomy, but again, very strongly controls appetite, to the point where some ladies might see me in clinic here, 6 months or a year later and say, God, I'm really not hungry at all. I'm completely released from that drive to eat. I almost have to remind myself to eat. And that powerful suppression of hunger is key to it working. But there's one other additional effect of the bypass, which in my opinion can be a useful deterrent. And that's really this side effect called dumping syndrome. So for most people, not everybody gets dumping syndrome, but for most people, if they eat high sugar containing foods, they'll get this group of really unpleasant side effects or symptoms: nausea, sweating, abdominal cramps, often diarrhea, then overwhelming drowsiness, you sleep it off, and then you're fine. And those sort of unpleasant side effects triggered by eating sugar can be a useful deterrent. Because the difficulty with the sleeve gastrectomy is that weight regain in the future is a concern. And for most people, they might say, look, it's got easier to eat, I can eat more, but the sleeve will never stretch to anything like the original capacity of the stomach. But what I think does come in is, with time, it does get it difficult to stick on a good diet, to continue to eat well. And there is a temptation to favour foods that maybe go down more easily with the sleeve. And for most people, those are high sugar containing foods: chocolate, sweets, cakes, biscuits, ice cream, smoothies, alcohol, and the one savoury food is crisps. So if you're honest with yourself and you know that those foods feature very strongly in your diet and you're pretty sure that you won't be able to avoid them after surgery, then maybe for those small group of people, a gastric bypass might be a better option. So as we said, the sleeve gastrectomy really works by physically restricting portion size and controlling appetite. The gastric bypass works by physically controlling portion size, strongly controlling hunger, and also this side effect of dumping syndrome. And when you look at the outcomes of the study, yes, I think it's fair to say that for most people, probably you would get a little bit greater weight loss with the gastric bypass than the sleeve gastrectomy. But if you're somebody who's young, active, eats well, but just eats too much, doesn't really have a sweet tooth, there's no reason why you shouldn't get just as good weight loss with a sleeve gastrectomy as you would have got with a gastric bypass. And so there is a temptation for a lot of people to say, look, I really want as much weight loss as possible. I'm going to go for the gastric bypass. But you've got to remember that that additional weight loss, that may be only a stone or less for some people, really comes at a very significant price. Yes, we do the gastric bypasses really well and complications in our hands are uncommon, but there is still an increased risk of serious complications with the gastric bypass compared to the sleeve gastrectomy. But my concern really is actually in the longer run. In the longer run with the sleeve gastrectomy, complications are very unlikely. The one thing we do see with the sleeve gastrectomy is some people do get heartburn and reflux with it, and that can be a reason not to have the sleeve gastrectomy. But equally, it's not necessarily a definite reason not to have it. If you've just got mild reflux that's very weight related and you know that when you're lighter you don't really get reflux, then a sleeve gastrectomy can still be a good choice. But if you're somebody who gets really very severe heartburn, it's resistant to medication, you actually physically feel acid coming up into your mouth, then you may actually be better off with a gastric bypass that was originally developed for people with intractable reflux before we had drugs like omeprazole and those sorts of things. But for most people, the sleeve gastrectomy is a very good operation and is very unlikely to give long-term difficulty. Whereas the bypass, we do see trouble with sometimes people getting ulcers that cause a lot of pain, make it very difficult to eat well. Sometimes getting abdominal pain that we can't work out. We can't work out what's caused it. Sometimes getting bowel trapped internally and things like that. Or sometimes struggling with nutrition in the future. So we do see much more difficulty with the bypass in the longer term than we do with a sleeve gastrectomy. It's also important to think very much about your lifestyle. Now, with the bypass, really you shouldn't smoke at all, because smoking causes ulcers in the bypass and they just don't heal in smokers. So if smoking is a part of your social life, really don't have a bypass, look at the sleeve gastrectomy. If you're absolutely sure you can stop smoking, then maybe a bypass might be an option. But if there's any doubt, have a sleeve gastrectomy. Similarly, alcohol with the bypass, because the pouch is so small, because the alcohol hits the small bowel so quickly, the effect of alcohol is very dramatic after a bypass. You essentially get drunk very, very quickly. You sort of sober up quickly too. But I've been in trouble for saying this in the past. You can become embarrassingly drunk with the bypass. And I think for most people, if you're having a bypass, you really want to err on the side of only drinking alcohol very occasionally. Probably better if you can be to be teetotal. So that's why I often say that sleeve gastrectomy suits young people very well, because it's much more compatible with a younger person's lifestyle. If you want to go out with friends, if you want to have a glass of wine, if you want to go out to dinner and those sorts of things, it's probably a bit easier with a sleeve gastrectomy than a gastric bypass. Similarly, travelling, most operations you can travel well with, but if you were to run into trouble with the bypass in a foreign country, it might be harder to find specialist help, whereas the sleeve gastrectomy you're very unlikely to run into trouble while you're on holiday. And then the last thing to think about really is the long-term maintenance of each procedure. And sure, with both procedures we want you to take your multivitamins each day and we want you to have your blood tests each year, but I think it's fair to say that's absolutely essential with the bypass, less so with the sleeve. And for most people with the sleeve, it's very unlikely that you'd run into nutritional problems in the future. Yes, we want you to have your vitamin B12 injections like the bypass, and watch out for your iron as well. But for most people, you won't run into vitamin or mineral deficiencies with the sleeve. Whereas if you don't really work well with the bypass, if you don't really follow the dietary advice very closely, it's possible that you could run into trouble with the bypass. So that's really a whistle-stop tour of the two procedures and how I think about how they work, how they fit in with patients' diets, patients' lifestyles, so those sorts of things. But clearly, this little chat isn't going to be better than a consultation with myself or one of my colleagues to really nail down your variations, how your diet works, how active you are, how well you've dieted in the past, whether you're a sweet tooth or a savoury tooth, and most importantly, to look at your expectations when making the decision. But I guess if we were to just look at my philosophy, and that would be very much that for most people, a sleeve gastrectomy is a good option, and probably not to consider the gastric bypass unless there's very important things in your sort of medical past or in your diet that will probably predict you doing much better with a bypass than a sleeve. And the last thing to say is that weight regain is a problem with any operation, whether it's the sleeve or the gastric bypass. But the difference between the two is that if you've had a sleeve and you do gain weight, say 10, 15 years down the line, you can always convert that sleeve to a bypass. Whereas if you regain weight with the bypass, which does happen unfortunately from time to time, there really is nowhere to go. So again, for most young people, that's why I'd recommend a sleeve, because it might give them really good 10 or 15 years, but if they then gain weight, they can have a bypass at that point, because unfortunately obesity is a lifelong condition, and probably there isn't one procedure which will do it forever. So that's very much my philosophy and how I work with a patient to make a good decision. But best of luck with your choices, and obviously we hope you get a really good outcome from your surgery.